Hello there, welcome back. This is going to be part 2 of multilocular well-defined lesions. We already covered myxoma and ameloblastoma, so now we're going to get into central giant cell granuloma and hemangioma, aka AV malformation. I'm also going to introduce you to aneurysmal bone cyst, and then topic 3, we're going to talk more about the rare tumors, and I'll do a bunch of practice cases for you to see if hopefully you've been learning some stuff here. Let's get going. All right, and on to the C of our MACHO acronym, which is central giant cell granuloma. Not really known etiology. It's treated as a benign tumor, but it can behave aggressively, especially in the maxilla. This one does typically occur in younger patients. Myxoma, we said a little bit younger, but there was kind of a wide age range. This one happens to be younger than 20 in most cases, and it can occur in very young patients. We see this example right here. As with most benign tumors, it's usually involved with the painless swelling, but in this case, the mucosa may have a purple color that's unique to CGCG. There is an aggressive variant that occurs in even younger patients on average. That one may be associated with pain, very rapid growth, so cortical perforation. There are some syndromes that this is associated with it. The more common one is cherubism, which we will cover later. And then the more rare one is going to be Noonan syndrome, where they have short stature related to congenital heart defects, wide and webbed neck. But that one is pretty rare. And onto our imaging features of CGCGs, more common in the mandible, but not exclusive. This is unique to CGCG as the anterior location. The epicenter is anterior to the first molar. Typically well defined, although it may be similar to myxoma, it might not have that much of a cortication. As we see in this case here, it's not as well corticated as you see with ameloblastoma. And what do you notice about the septations as well? Not quite as coarse and well defined, a little bit more wispy. They are kind of straight like myxoma, but they're even more wispy than a myxoma. And so wispy septation like myxoma, but usually more round loculations like ameloblastoma. And these can be quite expansile, so that's more similar to ameloblastoma. So they displace, they resorb teeth. Sometimes they can behave very aggressively and start to perforate the cortices. All right, so what do you notice about these ones? Let's focus on this PA first, the periapical. It looks expansile, maybe hard to recognize the internal structure. It doesn't have that nice, well-defined loculations like we'd like to see for a macho lesion, but there are kind of wispy calcifications interiorly. And then also focus on the age. The age, I think, is a big thing that drives differential for this. Age and location, more central. This is more of your CGCG than it is ameloblastoma based on those two things. Let's look at these CT images. So an axial slice through the maxilla, we can see a healthy maxillary sinus on the right side. But then this expansile, opacified area with some calcifications internally doesn't have that really nice marcated multilocular appearance, but more granular septations. I believe this is the same case in the coronal view, where you can still appreciate those wispy septations. The expansion pattern, though, is similar to ameloblastoma, and so a lot about this should lead you toward central giant cell granuloma. Same one with these cases, not those nice, coarse, well-defined soap bubble loculations like with ameloblastoma, although the expansion pattern is similar. Maybe if we knew the age of this patient, it would help. Assume it's a younger age, as we expect with CGCG. And then this arrow is pointing out one of the septations coming about 90 degrees to the margin of the lesion, to the external surface of the lesion. And that's kind of unique to CGCG as well. This shows that same thing from an occlusal view. Kind of wispy septations, but pretty outward expansile on the buccal surface. In this case, it was lingual and buccal. Another couple of occlusal views, all showing the same things. Kind of thin cortical outlines from the periosteum, so it's somewhat slow growing, but it does expand fairly rapidly compared to other benign tumors. So hopefully you're starting to recognize these after seeing a few examples. And when these do reach the periphery, this may be termed a peripheral giant cell granuloma rather than central. It's the same lesion, but just occurs more on the gingiva, and that'll leave kind of a purplish red color. But we see the occlusal view here, and hopefully you can appreciate a little bit of that wispy septation as well. All right, so here's our differential slide for CGCG. Remember the septation. What is it like for CGCG? More wispy. Kind of more straight like myxoma, not quite the soap bubble like ameloblastoma, but they're just more grainy. It can almost look like a fibroosseous lesion. And then I would say as far as aneurysmal bone cyst, we'll talk about that briefly. Keep that in mind whenever you see a central giant cell granuloma as maybe a variant. It's not really a variant of it, but it's really similar to central giant cell granuloma. Affects younger patients. It does have giant cells, although this one, the term is aneurysmal. And so this is more related to vasculature, but very similar as far as differential for giant cell granuloma. If it does have that granular appearance, maybe you'll compare it with an ossifying fibroma. Tend to see those small wispy septation in CGCG and not so much in ossifying fibroma. For ameloblastoma is going to have the coarse curved septation, more the soap bubble appearance, and typically in an older population. Myxoma slightly older. We said this was younger than ameloblastoma, but not quite as young as CGCG. So of course there's going to be some overlap there. But these do have the sharper, more well-defined septation. Those straight, angulated loculations really set this apart as myxoma. And I just described aneurysmal bone cyst contrasting with CGCG. Maybe the big difference here is this is more often posterior, where CGCG, the unique thing about it was the location, or one of the unique things was the location. But this is even more expansile than CGCG, although CGCG itself can be quite expansile. Simple bone cyst, what's the effect on teeth? This is the big one that leaves the lamina dura intact, if you remember that. Most of these other lesions, most benign tumors, are going to resorb the lamina dura of teeth. And simple bone cyst tends to not be expansile at all, whereas the other ones are. Specifically ameloblastoma, CGCG, aneurysmal bone cyst, whereas myxoma and OKC are more kind of gently expanding along the bone without expanding through the cortex. All right, keep this point in mind. Brown tumor of hyperparathyroidism. We'll talk about systemic diseases later. And so if someone is over 20 years old and you suspect a central giant cell granuloma, maybe you've done the biopsy and had the histopathology report, and it comes out as a giant cell lesion, think of potential hyperparathyroidism if they're over 20. So you're going to test for calcium and parathyroid hormone. All right, quick thought question for you now. Which variant of ameloblastoma would most likely be confused with a CGCG? Well, let's think about location first. CGCG is in the anterior most commonly, whereas ameloblastoma, the most common type, the solid type, is more common in the posterior. So if you go by location alone, desmoplastic ameloblastoma was the one that occurs in the anterior, so that could be confused. Also, desmoplastic ameloblastoma doesn't have those thick, coarse septation, not as likely to look like the true soap bubble appearance like your multicystic ameloblastoma does. And so overall, I would say desmoplastic fibroma, but as far as just the pure multilocular appearance, the multilocular ameloblastoma, the solid type, may be confused with a CGCG. But keep the age in mind too. Age is quite a difference. Now we're on to H, or hemangioma, and try not to get confused because there's a lot of different nomenclature. I'm mainly talking about vascular anomalies, and what we typically call hemangiomas of the jaws are really these arteriovenous malformations, sometimes venous malformations, which radiographically it's going to be really tough to distinguish between the two. But just to get our nomenclature straight, I want to talk about all these different types of vascular anomalies real quickly. And so we've got these two buckets, vascular tumors like hemangiomas of infancy. And in most cases, when a doctor talks about hemangioma, that's what they're talking about, these red masses that often occur on the scalp of infants. There's also congenital hemangiomas. And then the thing that affects us from the radiology perspective is more the vascular malformations. And in fact, a more common vascular malformation is capillary malformations or port wine stains. There's also lymphatic malformations, and a lot of these sometimes can be combined. And so we're going to focus on these two, the venous malformation and arteriovenous malformation. So vascular malformation, like it sounds, it's just a proliferation of blood vessels. It resembles a neoplasm, but just kind of a irregular proliferation of these blood vessels that coalesce and merge with each other. The venous ones are going to be low flow. They can form phleboliths. In fact, they're more common to flow phleboliths. Arteriovenous are high flow, and so now we have a combination of the vasculature of arteries combining with veins. And so direct communication between artery and vein. They can hemorrhage. These are the ones that are really bad to cut into because of that high pressure, that high flow. This is where a patient could exsanguinate. So be really careful when you suspect something might be one of these vascular or specifically the arteriovenous malformations. And so these AVM malformations are what we used to call the old central hemangiomas. I still like referring it to hemangiomas mainly so we can stay true to our acronym, right? The MACHO acronym. If this changed to AV malformation, then I no longer get to show you Macho Man and do my impression of him. And so when we say hemangioma, just keep in mind, we're typically talking about this venous, maybe arteriovenous malformations. All right, and this one is the high stakes slide of this whole video, so pay close attention. Intrabony arteriovenous malformations, most common under 30. usually in the posterior mandible, often right within the alveolar canal. In fact, that's where they more often form, although they can form somewhere else in the jaws. It's going to be a bony, hard swelling. If it's painful, it's going to be throbbing, loosening, and migrating teeth. That's not unique to this, but that can happen with benign tumors. Bleeding from the gingiva. This is unique to this. Rebound mobility, meaning you can press down on the tooth. If there's a AV malformation directly beneath that tooth, you may be able to press it down and then it comes back up. And so if you suspect these, you've really got to aspirate, meaning you go in with the syringe and you aspirate with the syringe. And if blood comes out, that's a good indicator that could be one of these. If you're not prepared to control heavy bleeding, you probably don't want to treat these. In fact, the surgery text always talks about any intrabony lesion to aspirate before cutting into it. And this is the reason. It might be an arteriovenous malformation and the patient could bleed out. So if it's in the canal, it tends to form this serpentine shape, as we see here in this image. Well defined because it's not a true benign tumor, but it behaves like a benign tumor. And so that's one common form of it. But another one, if it occurs elsewhere in bone, a lot of times it has these small loculations. So similar to a honeycomb type of ameloblastoma. And behaving like a benign tumor, it can resorb teeth. It can do all these other things that benign tumors do. And so the slide asks you why treat it soon and carefully. Well, the answer is what I just said, and probably matters more than anything else in this entire topic. If you biopsy one of these or extract a tooth, without considering what's underneath it, thinking maybe it's an ordinary periapical cyst, but it happens to be an AV malformation, the patient could bleed catastrophically. People have died this way. So when a posterior mandibular multilocular lesion or in a large canal, throbbing, mobile teeth, any of these signs, think of other signs. The multilocular honeycomb appearance, be really careful of those. Also, this can cause the sunray periosteo reaction. Any of these other signs, be really careful. If you're not ready to control that bleeding, don't touch it. If you aspirate and get blood, then stop and refer. So don't be that dentist that causes a catastrophic mistake like this. For the next several slides, I'm just going to give you several examples of these. I just stated it can cause that sunburst or sunray appearance. First thing you think when you see this is osteosarcoma, but just keep that in the back of your mind that hemangioma can do it as well. Then I talked about the small loculations, a very honeycomb appearance. It can appear that way. Or it can occur within the canal, and it's probably the more common one, but a lot of different variations that you're going to see with this. And so this kind of serpentine enlarging canal, and then it's widened right in the middle foramen. But it looks very benign, doesn't it? Can you appreciate those well-defined corticated borders, nice and smooth borders around that lesion? And so I said location, location, location. You see something that looks like it's arising within the canal, maybe exiting the canal in this case. Think neurovascular, because those are the structures that we have here. And so by vascular, this is what we mean, a venous or an arteriovenous malformation. A couple more examples here. A nice, well-defined round lesion. You can have a lot of things on the differential for this, but think about the location, and this may be arising right around the mental foramen. And so that location is telling you maybe hemangioma should be on your differential. Maybe you don't want to cut into this and have the risk of the patient bleeding out. But this could be something like a unicystic ameloblastoma, OKC, a number of other things. There's not anything super distinct about that one. This one kind of does show that sunburst or sunray periosteal reaction, but it does behave somewhat like a benign tumor. Then hemangioma might be first on your differential. Or again, when I say hemangioma, what I'm referring to is venous or arteriovenous malformation. And we haven't done the soft tissue calcification lecture. When we do, we'll talk more about phleboliths, where they tend to occur. But in 95% of cases, when you see phleboliths anywhere in the head and neck, it's going to be associated with a vascular malformation, either venous or arteriovenous malformation. This happens more commonly in venous, but like I said, radiographically, we can't really distinguish. So maybe the first thing that comes to mind is the H from the MACHO acronym, hemangioma, and just remember that's referring to one of these two things. And I think this is an interesting slide real quick. This can have an effect on the size and the eruption pattern of teeth. If you have a hemangioma, you don't really see much evidence of it. This sinus looks cloudy, but that could mean a number of different things. But there's actually a hemangioma here that's causing enlargement of these teeth. It's causing premature growth and then eruption of this premolar compared to the other side, which this is more normal if you compare to the other teeth. But this one was large enough actually to affect both the maxillary and mandibular teeth. So we shed eruption pattern as well as size. This clinical photo shows you the difference in size of these two maxillary deciduous cuspids. All right, what do you see here? You see a nice well-defined serpentine shape. It's kind of causing a curving of the inferior alveolar canal. So again, you're thinking neurovascular. So far, we've talked about hemangioma or AV malformation as being the one to cause that serpentine-shaped canal. And one last interesting finding here. So if you remember back to first year and I talked about different extraoral views, we used to do more of these Waters view where you would tilt the patient up and that would get a good look into the sinuses. You can see there's just some mucosal thickening in the left one, which is not terribly uncommon, but the right sinus looks completely opacified. Now that could be just sinus disease. Sinusitis causes fluid buildup in the sinus. So I don't really see a lot of other signs going on in the sinus, but here they did an angiogram where they inject a radiopaque dye into the vasculature, and that'll enhance visualization of vasculature and arteries depending on the timing of when you do this. And then they did a lateral ceph, and you can really see the vasculature, and that's not normal. That's showing that there's a vascular lesion, whether it's venous or arteriovenous. So that pretty much does it for the MACHO acronym. You'll notice I didn't talk about the O. The O is for OKC, because we talked about that with the new unilocular lesions. Just know that it can appear multilocular. Sometimes it appears similar to an ameloblastoma, but if you have that true round soap bubble, small loculations, that's not so much your OKC. And I did kind of talk about how to differentiate the two. OKC expands more along the bone without really widening buccal or lingually or supra-inferiorly. So pay attention to that expansion pattern, and hopefully you'll be able to identify OKC versus ameloblastoma. But let's go on to some of the more rare ones. I did already talk about aneurysmal bone cyst, or ABC, and I said always pair that with CGCG. In the back of my mind, when I'm thinking CGCG, I think, could it be an aneurysmal bone cyst? If it's more posterior, really expansile, of course CGCG can be quite expansile, then start thinking aneurysmal bone cyst. So if anything, think of this maybe like the vascular cousin of CGCG. Behaves like a benign tumor, but it's more a proliferation of blood-filled vascular spaces. If we did the histology of this, looked at it under a microscope, you'd see all of these fairly large blood-filled vascular spaces. Over 90% are going to be under 30, so that's somewhat similar to the age group as CGCG. Rapid swelling, sometimes pain in this case, so maybe a little bit different than most benign tumors and cysts. But unlike CGCG and like other typical tumors or cysts, this occurs more in the posterior, somewhat more in the mandible. Well-defined wispy septa, so in a lot of regards it can look just like a CGCG. That's why I kind of pair those two in my differential diagnoses. And then similar to arteriovenous malformation, if you aspirate these, because they have a lot of vascular spaces, you're going to get some blood, and so expect that. The same caution applies. Maybe not quite as high pressure blood flow as an arteriovenous malformation, but these could bleed quite a bit. All right, so looking at these and comparing to all these other lesions we talked about, I think they look a lot like central giant cell granulomas, but it has that more wispy septation appearance like CGCG does. And this one happens to be more in the posterior. This one is quite expansile. This is the same lesion, just different views, different windows, but very expansile. Maybe a really expansile CGCG definitely have aneurysmal bone cyst on the differential.